Dr. Takashi Akasaka for his talk on role on imaging in left main bifurcation PCI.
Okay. It is really my great honor and pleasure to be here again, and thank you for kind invitation. Today's my talk is role of imaging in left main bifurcation PCI. This is my disclosure slide. As you know, bifurcation lesion PCI might be 15 to 20% of all PCI cases in our daily clinical practice, and complex procedure might be required sometimes. And higher risk for complications such as side branch occlusion, stent thrombosis, stenosis, and so on has been reported more frequently in bifurcation lesion PCI. This is a data compared with single crossover and two-stent strategy. Compared with two-stent strategy, single stent is better prognosis, as shown in this slide. This is a meta-analysis comparison, provisional versus systematic double-stent strategies. As shown in this slide, single stent technique is better compared with favorable double stent strategy. This is different two-stent technique in left main bifurcation as compared with provisional, as shown in this slide. Culotte or DK crash or mini crash might be better in cardiac death, stent thrombosis, TVR, and so on. And also, T-stent is better in TVR and MI, as shown in this slide. And generally speaking, a DK crash might be better compared with other technique. And physiology is useful to predict the future MACE. Yes, this is an adjusted 5-year event rate according to FFR in LCX after left main simple crossover stenting. If the patient with FFR more than 0.80 in LCX had better 5-year outcome than those less than or equal 0.80. However, event rate increase even though FFR is more than 0.80 if leave it alone more than 4 or 5 years. What happened in this case? This is one of the representative case of 3D OCT image of LCX stenosis after left main bifurcation crossover stenting. 3D OCT clearly demonstrate a stenosis by the neo-intimal proliferation at the left main bifurcation with 3 LCX different orifices as shown in this slide. Why? Because if you succeed to select the distal cell, you may have no metal carina. However, if you select the yes, proximal cell, you have the metal carina, and here might be the shear stress is lower, and restenosis may happen with the stent thrombosis. And this right-hand side demonstrates if there are no jailed stud, you may never lose the orifice, but simple jail and complex jail makes much more restenosis as shown in this slide. Yes, this is one of the example of left main bifurcation lesion. After pre-dilatation, we did an IVAS, and IVAS demonstrate severe stenosis in just distal to left main, right? And we measured the reference site and also the stenosis site as shown in this slide. So how to decide the stent size? If you use a vessel area, mean diameter should be less, yes, quarter size smaller. And if you use the lumen, you have to select the quarter size bigger and avoid the distal landing zone and the plaque burden less than 50%, and the non-lipidic portion might be ideal. And yes, this we before putting a stent, we did an IVAS marking to identify the orifice of the left main. So still there are lots of plaque in this region, and IVAS marking should be important to identify the left main ostium for stenting delivering to left main orifice. And this is a KBT after a part. Yes, before finishing the procedure, it is important to check the edge dissection, stent position, and expansion and bifurcation and left main orifice condition by imaging to obtain optimal results. Right, and this is a still frame. The MLA site is more than 9 millimeter square, and there are no edge dissection, and the position is okay. Right, so how to decide the optimization, right? MSA should be more than 5.5 square millimeter, and malposition should be less than 400 micron, 1 millimeter length, and distal edge dissection less than 60 degree, and flap should be limited in intima and less than 2 millimeter length. And compared with an IVUS-guided and angio-guided PCI, this is a Swedish coronary angiography and angioplasty registry, SCAR registry, compared with an angio-guided, IVUS-guided demonstrate better prognosis. And this is from Korea, very basic data, two-stent strategy demonstrate much more ISR, and also the 5, 6, 7, 8 square millimeter rule is still used in our daily clinical practice. Based on these data, IVUS is recommended for left main bifurcation. But how about the OCT? OCT can clearly see the left main orifice if you use a telescope, as shown in this slide. This is compared with IVUS and OCT, and by OCT, a position indicator with color bar can demonstrate incomplete position by 3D reconstruction by flying through image with short axis view and longitudinal view. Color bar demonstrate the incomplete position by red. And this is one of the case. We try to put a stent just proximal portion. However, a stent elongation makes an incomplete position at the bifurcation. Then we did a port, and we can make a very good cell condition in the distal portion. Then we have succeed to select the distal cell with blind manner, and then after port we can get a good result. And this is the final result. And here is the red color is the side branch position, and white color demonstrate a position in the proximal site, and under expansion can be identified a little bit, right? And there are some recommendations where we have to select by the side branch orifice, as shown in this slide. Yes, we can succeed to select the side branch blind manner nearly 40 to 50%, as shown in this slide. But sometimes it is difficult. At that time, you try to use a dual lumen catheter. If the dual lumen catheter goes in, the wire is the same cell, but it is difficult to push in that you succeed to select the distal cell. If you succeed the distal cell and KBT you demonstrate can get a very optimal result, as shown in this slide. However, even if you select the distal cell, if there are a link at the orifice, you may have still lots of strut and deformation of the main branch strut. And if you succeed proximal cell, if there are a link, you cannot obtain a good result. There are still metal carina, and it may make stenosis. This is one of the pilot study from Japan. If there are no link and you succeed distal cell, the result is ideal. However, only a few may make not enough data. But if there are no link, it might be very difficult to obtain a good result. The suboptimal result might be yes, you can speculate. Therefore, it depends on the case. At that time you leave it alone without any kissing balloon technique, because if there are yes, suboptimal results in complete center position can be higher, and incident stenosis is numerically higher but statistically not significant. Therefore, we did a multi-center randomized study in Japan, and this is the result. If there are link free, you can obtain the optimal result, but still link connecting type, suboptimal result is 35%. And this is an October study recently published. OCT guided PCI at the left main bifurcation is better compared with angio guide, and as shown in this slide, yes. However, the one stent technique, we crossover demonstrate a better prognosis. However, we cannot obtain a good result to stent and acute myocardial infarction or calcified lesion, as shown in this slide. And this is a calcified lesion. You can identify the very tight stenosis at the bifurcation. And here is another view, a spider view. And after yes, orbiter and low tabulator, we can obtain a good ablation here, as shown in the right-hand side. And this is an orbiter, low speed, high speed. And finally, after rotor, we can obtain a good lumen area. So in addition to easy to access the two branch to assess anatomic relevance of the two branch and to estimate plaque morphology and disease extent in the two branches should be very important in left main bifurcation PCI, and therefore imaging guidance should be mandatory to obtain better clinical outcome. This is my take-home message. Thank you very much for your kind attention.